Shall I start, ma'am?
Yes, Alia.
Yeah. Can you see me? Good evening, everyone. I would like to welcome you all to the second presentation of basic modules in infectious disease. Today's topic will be clinical microbiology, gram-positive bacteria of the Staphylococcus series. It is organized by Federation of Clinical Pharmacists of India, the ID Forum. Before we begin, I would like to quickly go through some instructions. Participants, you can post your questions in the comment box below the video thumbnail in the website, or you can send it as a mail to the FCPI officials at gmail.com. Then you can download your certificates after you complete the feedback form, which will be made available at the end of the towards the end of the sessions in the of the thing. Then presentation slides you can download from tomorrow. From tomorrow you can download the presentation slides. Without any further ado, I would like to welcome Dr. Grace Mary John from the BCIDP. She's the Infectious Disease Forum member of FCPI, Federation of Clinical Pharmacists of India. Over to you, ma'am.
Thank you, Alia, for your kind introduction. So I would like to start off with the clinical microbiology for the gram-positive bacteria. And I thought this is one of the major bacteria we all should be knowing about. So Staphylococcus. And in the forthcoming presentations, I'll be going through the Streptococcus and the other infections as well. For disclosures, I do not have any relevant financial relationship or any commercial interest for doing this presentation. And the learning objectives is to know the basics in microbiology and to emphasize on the differences between the gram-positive and the gram-negative bacteria, and to know the fundamentals with regard to gram-positive bacteria and the antimicrobial agents that are effective against these gram-positive bacteria. So like I said in this presentation, I'll be taking you through the Staphylococcus species that comes under the gram-positive bacteria. In the last presentation by Dr. Sangeeta, she had taken you through the gram staining process. So how do you classify a bacteria? So we know that Christian Gram developed this technique in the 1800s, where you can differentiate a bacteria being a gram-positive or gram-negative based on the staining it does. That is, in the microscopic view, as you can see in this figure, first crystal violet, which is very deep violet in color, is added, and then iodine is added. And when you wash it off with alcohol, the ones that are retaining the violet color, those becomes the gram-positive. And for those organisms that when you put the, after putting the saffron in, that washed away crystal violet versus the saffron, and whenever you get the pink color, that gives you your gram-negative bacteria. And this has been shown to you in the last session as well. The reason for this is because the gram-positive have a very thick peptidoglycan layer, and therefore, when you introduce alcohol, ethyl alcohol, during your gram staining process, the crystal violet is being retained in the organism's cell, and that's why it is showing as gram-positive or the violet color. And the major differences that you can see is that gram-positives versus gram-negative, like I said, the peptidoglycan is the one major thing. And when it comes to the gram-negative, it is usually the lipopolysaccharide and the other membranes that are surrounding the bacteria. And when it comes to gram-negatives, they have the capacity to produce the endotoxin, which is the lipopolysaccharide that you can see over here. And there is, again, foreign channels, periplasmic space, a lot of differences when it comes to gram-negatives, and none of this exists for the gram-positive. So after staining, this is what you will see if you look it through a microscope. I have color coded it. So the gram positive, again, violet, and the gram negative, the pink. Now, morphology, coming to the morphology, it really matters, especially if you are in a clinical setting, what your lab gives you, the data that the lab gives you, unless you are able to crack what they are giving to you, it will be of no use. It is very essential to have the morphology, especially the gram stained. So let me go through a case with you to make you understand better. A 45-year-old man with uncontrolled diabetes is coming to you in ER with complaints of fever, with cough, with expectoration. At the time, the patient is hypotensive, he's tachycardic, X-ray shows a right lung consolidation. The initial cultures were drawn and gram stain was done for this patient. The gram stain showed gram-positive cocci in pairs. What could be the possible organisms? What could be the possible organism in this patient? So one thing I want to stress here is that the culture that you usually take, it will easily get 2 to 3 days before you can isolate the exact organism. But the gram stain can be done in a very short time, and you will get your gram stain reports, without much delay once the sample has been given to the laboratory. So which one among these organisms do you think is causing the infection in this patient? Is it E. coli, or is it Klebsiella, or is it Staphylococcus, or is it Neisseria, or is it Streptococcus? Think on the answer and see what the gram stain tells you. So these are the subtle things that, from the lab you get, based on which you can easily come to a conclusion. So this is a straightforward case of Streptococcus because it's a respiratory syndrome that the patient is presenting you with. It's a pneumonia, and the number one cause for pneumonia is usually Streptococcus pneumoniae. And it is a gram-positive cocci, which is in pairs. When you compare it with Staphylococcus, it is gram-positive cocci in clusters. So now once you know that it's a streptococci, the next thing that you can think is, what is my resistance rates for streptococci? What is the drug that I'm already giving this patient? Do I have to cover something extra? Because if this was a gram-positive clusters for this patient, and if it's Staphylococcus, and if my hospital rates of staphylococcal MRSA is very high, I would want to add a gram-positive cover to this patient initially. I can't wait for maybe 3 days, by the time the patient can go into, already the patient is in sepsis, the patient can deteriorate. So these are the subtle things that you can make out from the morphology. And coming to the details, the gram positives are usually cocci, and the three main organisms that we encounter in our daily practices are Staphylococcus, Streptococcus, and Enterococcus. And the gram negatives are usually rod-shaped or bacillus, and we know the E. coli, Enterobacteriaceae, Pseudomonas haemophilus, and the bacterioids, which are the anaerobes. But there are exceptions. There are certain gram negatives that can come as cocci. So example is Neisseria, Moraxella, and also in the gram positives also, some can be bacillus. Some can be rod-shaped, which are the Corynebacterium, Listeria, Clostridium, and there are other shapes as well. Now, when it comes to the classification of gram-positive bacteria, first you classify the bacteria based on the morphology. Okay, so is it a gram-positive cocci or is it a gram-positive bacilli? And in that, you have aerobes and anaerobes. So in the gram-positive cocci, it's usually the aerobes and the three organisms that I've already talked to you about, staph, strep, and enterococcus. These are the three major culprits. But when you come to bacilli, first is the anaerobic, which are the Corynebacterium, Listeria, and Bacillus. And obviously, our Clostridium species are anaerobic in nature. This is one way of classifying your gram-positive bacteria based on the shape and their requirement for oxygen. Now, coming to a second case, you have an 11-year-old boy who develops a mild fever and pain in his upper arm. A radiograph of his arm shows a lytic lesion. That means there is some breakdown of the lytic lesion of the upper part of the humerus with periosteal elevation over the lesion. That means there is some breakdown in the humerus bone, and there is a mild elevation, which probably could be an abscess or a collection. The patient is taken to surgery where the lesion is debrided, that is a dead bone, and the pus were removed. Culture from the lesion yield gram-positive cocci. Again, so the three major gram-positive cocci, like I told you, is staph, strep, and enterococcus. Now, a test shows that the organism is Staphylococcus and not a streptococcus. Based on this information, your organism is the organism susceptible to nafcillin, or if the organism a beta-lactamase positive or a producer, or is it a producer of the protein A, or is it encapsulated, or is it catalase positive? You can type in your answers just so that you can cross-check your knowledge with what you know so far. Okay. So based on this, we know that it's a gram-positive cocci. Okay, there are three major organisms, like I said, and through some test, we have found out that it is staph, not strep. So what could be that test is basically the question. Now, the tests that differentiate staph from strep is the catalase test. So now the next classification for the gram positives is based on the culture, the biochemical tests, and the other microbiological parameters. So again, for gram positive cocci, first you see if it is a catalase producer. So catalase is an enzyme that will break down hydrogen peroxide into water and oxygen. So when you put an organism that is catalase producing or introduce it into a hydrogen peroxide kind of medium, there will be a lot of bubbling. So which is usually your staph. So Staphylococcus is always catalase positive. Okay. And then once you know that it is Staphylococcus, again, among staph, there are multiple classifications based on their other biochemical tests and how they react to those tests. The major one is the coagulase. If it is coagulase positive, then that becomes your staph aureus. And if it is negative, it can be epidermidis, it can be saprophyticus, it can be, there are a lot of other things also, which I do not want to go into details because they are not clinically that relevant. All right. And this is how, so catalase test and coagulase test. Now, if your organism is catalase negative, that means it is streptococcus. And later, once you know that it is a streptococcus organism, based on the hemolysis, you classify your strep into alpha, beta, and gamma. So alpha is partial hemolysis, which encloses your strep pneumonia, like the case that initially saw, the respiratory pneumonia. So the strep pneumonia or the virulence group streptococci will come under, they cause partial hemolysis. Beta hemolytic is complete, they destroy it completely, and the ones that come under these classifications, the beta classification of the group A, streptococcus, which is the biogens, the algalactaceae, which is a group B, which is known to cause a lot of infection in the neonates. And then there is gamma. Gamma is nothing but your enterococci, which was earlier termed as group D streptococci. Now this group A, B, D and all are the Lancefield classification based on the proteins that the organism has. I will take you through this in detail in my next class on the rest of the gram-positive organisms. Now, coming to Staphylococcus. So, like you can see there on the right hand, I have put a small picture, a microscopic picture, which shows you like a bunch of grapes, right? It is, so the the nomenclature of Staphylococcus is derived from the Greek. Staphyle means grape-like cluster. So Staphylococcus is nothing but grape-like clusters of organism. And they are normally in many literatures say from 30 to 50% of people have Staphylococcus as their normal flora, either epidermidis or Staph aureus, especially in the healthcare workers. It is there in your skin or in your anterior nares. And again, like I said, gram stain, catalase, and culture are the ones that will help you decide which one it is. And the catalase enzyme, which causes hydrolysis of hydrogen peroxide. And the coagulase test is very essential to know whether your pathogen is quite bad one or not. Based on the coagulase positive, like I showed before, Staph aureus is positive, but the other two are actually gram negative. Coagulase negative. The other ones include Staphylococcus hominis, Staphylococcus warnii, etc., which are all coagulase negative. Coming to Staph aureus. Now, those who are listening to me, those who are listening to this presentation, Staph aureus is something that you must know inside out, because it is one of the baddest organisms that you can, the worst one you can actually encounter. Even though we don't see many cases of Staph aureus in India, but in healthcare, as healthcare is improving, we will encounter a lot of this bad guys. And for any ID clinician or ID physician, this is one of the most dreaded bacteria that they don't like, because it is difficult to get rid of. It is very aggressive, and it's a very bad bug to have. Now, like I've mentioned before, Staph aureus, it is catalase positive. So on your left, you can see that there is some bubbling here, right? So which is the hydrogen peroxide being broken down into oxygen and water. So the oxygen is what you see, the bubbling there. And the coagulase. Coagulase, it basically enhances coagulation, right? And they are facultative anaerobes. They are non-motile and non-spore forming. And how do you isolate them in the culture? So in the nutrient agar, it causes a golden yellow pigmented colonies. The term aureus means gold. So like you see here, they can produce golden colonies, and that's why it is called Staph aureus. And in the blood agar, the colonies have, like it said, when it comes to beta hemolysis for streptococci, there are multiple things, and for staph, the Staph aureus comes under the beta hemolysis. It causes hemolysis, and therefore that zone of hemolysis is visible when you put it in blood agar. And it is most virulent among all the Staphylococcus aureus Staphylococcus species that you have. And it can range from a simple food poisoning to a simple skin infection to very life-threatening systemic infections. And the implication for Staph aureus is that as the healthcare improves, as the healthcare spectrum is improving, when more people are getting treatment, more people are getting surgeries, more people are being exposed to the healthcare setups, these organisms and their infections also tend to go high. And that's why it's usually said we are not seeing so much of Staph aureus. It's always in the US, it's in Canada, in the Western world, Staph aureus is not a problem for India. But that's not true, because as we are progressing, as a nation, when we are progressing, this will become a threat to us also. So the growing number of healthcare associated infections, especially the device related infections and surgical related infections, are going to be higher. And this is the reason why we should be knowing this bug inside out. Now, why is it so dreaded? What is the reason why? Like I said, every ID physician hates this bug. Why does an ID physician not like this? Because it is very virulent, like I said. And what causes this virulence? What are the factors that helps this organism to be so bad? So there are multiple factors, multiple things the organism has in itself. Like it has a it has an armamentarium of weapons that it uses to destroy to disseminate the infection, to destroy the immune system. So I'll go through that quickly so that you will understand how bad or how dangerous this organism can be. So there are certain things the Staph aureus has, certain proteins it has to protect them against the immunity when it enters a host. So if I have a Staph aureus infection, there are a lot of proteins that protects this organism from my white blood cells killing these organisms. So one is protein A, and it prevents opsonization and phagocytosis. Now, coagulase, as you can derive from the name, it allows fibrin formation around the organism. So what happens is that when you have an infection, when you have a staph infection, the area where it is infected, around that area, it forms this fibrin and it becomes like a fort. It's like a cave that the organism is sitting. So it becomes difficult for our immune system to just destroy this cave and get into this inside of it to destroy the organism. So that's how the coagulase is very important. It forms a fort around the infection or the foci. Then there are hemolysins, that destroys your RBCs. Then you have leukocidins, which destroys your WBCs. Okay, and then our beta-lactamase enzymes like penicillinase and everything that act against the drugs that we give. So this is one, that the proteins that protect them against immunity. Then the ones that help them in invading, in tissue destruction. So you have hyaluronidase, which breaks down the connective tissue. So it helps in the dissemination. So once it gets into, it enters your body, using these enzymes, these proteins, they invade your other systems as well. So staphylococcus is nothing like it's like streptokinase. Why is streptokinase used for? It is to when a patient comes with stroke, we know that streptokinase is being used to dissolve the fluid, right? So staphylococcus is something very similar to that. And then you have lipase, which breaks down the lipid. And last, it has a lot of toxins. It can be an enterotoxin, it can be exotoxin. There are so many toxins that this bacteria produces. Like I said, the gram-positives, they don't have endotoxins, but they have exotoxins. So the enterotoxin, entero is gut, the enterotoxin. So whenever somebody takes something that is being infected by the Staph aureus bacteria, within 6 hours or so, food poisoning, the diarrhea, the vomiting, everything starts for that patient. It's because of this exotoxin that is being produced, which goes into your gut and does all this damage. Then there is exfoliatin. Exfoliatin, like we know that, especially the girls who are listening to me know that foliation is very essential for your skincare, to take care of all the dead cells and everything like that. So this is also a toxin that can cause something called skin sloughing. That means the skin peels off, which is a reason why it causes something called scalded skin syndrome in babies. And the most dangerous one is the toxic shock syndrome toxin, the TSST1, which is again an exotoxin, which is nothing but a super antigen. Like what happened in COVID? In COVID, we know that a lot of our lung tissue was being destroyed by iron immunity because it triggered our immune system to have cytokine storm to cause destruction to other organs as well. The same thing this bug can cause, toxic shock syndrome, especially in ladies who are using super absorbent tampons and also not just for that, perioperative, post-operative patients have also experienced this sudden onset toxin production, which leads to multiple multi-organ dysfunction. So this is why this bug is super bad. Now, because of this machinery, because of this, like I said, the armamentarium of things that this organism has, it has a wide clinical spectrum of infections that the Staph aureus can cause. From simple skin infection, which can be a folliculitis, it can be an acne kind of thing where your cell follicle, usually that Staph aureus, it's always like a pimple. It's like a pimple with some pus collection inside that you can see in the center. That is usually a Staph aureus infection. So from a small folliculitis to carbuncle, it can form an abscess, which can, because like it invades the tissue, it can go from that small infection to cellulitis and necrotizing fasciitis. Okay, so skin infections itself, they are bad. Then toxin mediated, they can cause toxic shock syndrome that I've told you about. Food poisoning, Staphylococcus scalded skin syndrome. When it comes to the musculoskeletal infections, from septic arthritis, osteomyelitis, pyomyositis, again, abscess like the case that we saw, the humerus having pus collection. So abscesses within the musculoskeletal, within the bones, it can happen. Then bacteremia, definitely, because once the bug enters your body, if it goes into your blood, from that blood, it goes everywhere, from your heart to your meninges to your lungs, anywhere you can think of, they can go and start creating abscesses. So that is one reason why we say that when you have Staph aureus bacteremia, you have to treat this very aggressively and very seriously. And also respiratory tract related infections, like a patient who is admitted to your ICU, who's on ventilator, if the MRSA rates are very high in your ICU, the good chance that the patient can have an MRSA VAP, or you can have septic pulmonary emboli, from other organs, from other, like an infective endocarditis, it can just shower emboli to your lungs and everywhere. And patients who are having post-viral pneumonia, especially influenza, after having an influenza, if a patient has improved and then coming with a bad consolidation, a necrotizing consolidation kind of thing, it could be very well be an MRSA. And then obviously the empyema that you see in your medicine or pulmonary posting is again, Staph aureus is one of the major causes for that. So the toxic shock syndrome that I told you about, it has a range of symptoms from fever, vomiting, diarrhea, myalgia, rash, hypotension, and goes into cardiac and renal failure in most cases. So in females who are using high absorbent tampons, after having their onset of menses, that is, once they start using that, usually after 5 days, when the patient comes with collapsed hypotensive, this could be one reason, which we don't see here in India much, but in the US, they do see this. But also, like it said, it can happen in children and men with staphylococcal wound infection as well. That's why we always give something to encounter the toxins that are produced by Staph aureus. Now, the resistance, coming to the resistance of Staph aureus, again, I have a case for you. A 65-year-old man who develops an abscess on the back of his neck. The culture yields Staph aureus. The isolate is tested and is found to be positive for MEC-A gene, which means the isolate is susceptible to Vanco, is resistant to Vanco, susceptible to nafcillin, resistant to nafcillin, susceptible or resistant to clindamycin. So what's your answer? You can type in your answers, you can write down your answers and then later compare. I'll give you 5 seconds. MEC-A gene, all right. Now coming to resistance, this is nothing but MRSA. This is a purely methicillin resistance, which means it is resistant to nafcillin. So beta-lactamase resistance, there are 2 major mechanisms that you need to know. One that is very common that you know in the gram negatives, it is a beta-lactamase enzyme. Enzymes that are produced by the bacteria to break down the drug, right? So the first major thing that you see is penicillinase. Okay, penicillinase means it breaks down penicillin. So that's why, because most of the Staph aureus organisms were becoming resistant to penicillin, that's why you developed your penicillinase resistant penicillin, which is your nafcillin, oxacillin, methicillin, cloxacillin, dicloxacillin, all these drugs, they can withstand this enzyme. All right. And then the other one that you can use if it's a beta-lactamase producer is the clavulinate or the sulbactam, which are the beta-lactamase inhibitors. Okay, so this is very clear cut. There is nothing to break our head open with. This one, beta-lactamase, is there in gram-negatives as well. Okay, so this is very straightforward. What I want you to listen to is the next one, the reason for MRSA. So we know that the many of the drug targets, especially for the beta-lactams, it is the penicillin binding protein. So what happens is that they alter this penicillin binding protein, and the gene that helps in this alteration is called the MEK-A gene. So what happens? This penicillin binding protein is essential for the cell wall synthesis of the organism, and this MEK-A gene encodes for the penicillin binding protein 2A. So once this gene is expressed, what will happen? It will cause the beta-lactams to have less affinity. See, once like the beta-lactams go and bind to the penicillin binding protein, if the organism has this gene, it is having less affinity to go and bind to this penicillin binding protein. Therefore, it causes resistance. And this is the reason why you have methicillin resistant, which is basically nothing but MRSA. We are talking about Staph aureus. Okay, so how do you detect MRSA? It is the resistance to oxacillin, nafcillin, all these penicillin resistant penicillase. If it is resistant, it is MRSA. And how do you do it in your lab? If your cefoxitin disc in your culture plate, if your cefoxitin disc is coming as resistant, that means it is methicillin resistant. Now, think next time when you go and see a patient, when you get a culture report in your hand, this is something I want you to go through. So if your organism is saying Staph aureus, then comes penicillin resistant, methicillin sensitive, vancomycin sensitive, linezolid sensitive, clindamycin sensitive, all other sensitive except for the penicillin, which is resistant. Most likely the mechanism of action is going to be the beta-lactamase production, the penicillinase. That Staph aureus produces that enzyme to make penicillin resistant against it, to break down penicillin. But when you see a Staph aureus report which shows penicillin resistant, oxacillin resistant, cefazolin resistant, cefuroxime resistant, ceftriaxone resistant, it is nothing but purely an MRSA. If you have oxacillin resistance, it is MRSA. Okay, so in your culture, try and find out. And now you know that if it is methicillin resistant, the reason for the resistance is the MEK-A gene. Okay, so that is something that that's how you learn your resistant mechanisms for organisms. You train yourself with the cultures that is in front of you. And the beta-lactamases are plasmid coded, while the MEK-A is usually chromosomally coded. Now, there are two major types of MRSA. Even though this classification that I'm going to tell you is losing its importance slowly, it is still essential for you to know the types of methicillin resistance. So it is nothing but community acquired and hospital acquired. So the MEK-A, like I told you, for community acquired, the strains expresses the 4, 5, and 6. For hospital acquired, it is 1, 2, and 3 for MEK-A gene. Okay, the subtypes. And there is something called the Staphylococcus cassette chromosome, that is SCC. So this is just like a cassette. Just think it of a a cassette which is having a lot of songs, right? We have seen cassettes with a lot of songs in our childhood. So it has a lot of songs, right? So like that, this SCC MEK has a lot of genes that confers resistance to various drugs. So if you look at the community acquired, the cassette is quite small because the number of genes that it carries, it's quite less. The number of genes are very less. But if it is hospital acquired, the cassette is quite big. It has a lot of number of genes. Therefore, it is usually multi-drug resistant. When it comes to hospital acquired, a lot of drugs will be resistant if it is a hospital acquired MRSA. But when it is community, it might not be that case because there are only a small number of things that causes genes that is encoding for the resistance. Now, there is something called the Pantone-Valentine toxin, which is seen in the community-acquired setup, and it is usually a cause or a toxin that causes outbreaks in the community-acquired MRSA strains. Now, like the community-acquired usually comes with invasive skin and soft tissue infection or diabetic foot ulcer or all these things, and it can go up to a necrotizing fasciitis. But hospital acquired is usually a perioperative, the post-operative surgical infections, and nosocomial VAP, HAP, all these things that we can get, from the hospital community. And problem is, we, the healthcare professionals, are usually the carriers for this MRSA. Now, what is a resistant like? Like I told you, I've always heard people say that India should not be worried about MRSA. It's for the West, but that's not true. When you look at the CDUP data, you can see that India is in a way burning in blue there. When you compare it with this guys here in the US, it is quite on the brighter side. I think this is, I am not sure, but I think it's because of the referral bias also, because the hospitals that are reporting are the tertiary care centers which have advanced cases and things like that. But when you compare it to the US and the Canada and the Western world, every hospital, give their data. But I think in India, it is because the tertiary cares are usually sending the data for this towards the resistance, how much resistance we have. But it is actually increasing in India. This is purely the data from India. And you can see that slowly, as the years are going by, there's a sudden jump from 2015 to 2018. Okay, and the rates are quite high there. And you can see that the resistance for Staphylococcus to usually the Staphylococcus aureus can be sensitive to fluoroquinolones and aminoglycosides, and the amoxicillin and ampicillins and everything. But almost 90 to 100% of this species that we isolate in India are resistant. That means no amoxicillin, no levofloxacin is going to work for Staph aureus in India soon, right? But also one thing I really want you to concentrate here is the aminopenicillin versus the aminopenicillin beta-lactamase. That is amoxicillin versus amoxicillin clavulinate. The amoxicillin clavulinate are quite good for Staph aureus. Okay, amoxicillin is not, because of the penicillinase that I was talking to you about. So when you have a beta-lactamase inhibitor, you might be able to get off with, if you have an MSSA, if amoxicillin clavulinate is sensitive, that's a good drug to give a patient. Now, I want to show you the spectrum. Okay, spectrum means what all drugs works for what all things, right? So this is something that we developed in-house, and I'm just showing you a part of it. And in the MSSA, you can see that in the MSSA, a lot of drugs you can use to treat the infection, ranging from your penicillin-resistant penicillinase like the oxacillin, amoxicillin clavulinate, but see, no amoxicillin. Amoxicillin is not used. So these are the ones that you can use. A lot of drugs that you can use to treat MSSA. But here we have classified into hospital-acquired and community-acquired. So for community-acquired, your clindamycin, your doxycycline, your Septran, everything can work. But when it comes to the hospital-acquired, it's not the same case. You have a lot of very few agents that you can use to treat hospital-acquired infection, hospital-acquired MRSA, like, vancomycin, ciprofloxacin, daptomycin, linezolid, and tigecycline. And there are newer agents that are coming, like dalbavancin, oritavancin. All these things have good, promising, long-acting molecules that you can use, which is not available in India so far. Now I have talked to you about the beta-lactam resistance, right? The beta-lactam, it is your amoxicillin, your cephalosporins, your meropenem, everything was beta-lactam. So you know that once, I just want to show you that also. Once you go into from the MSSA to MRSA, all these beta-lactams, you can see from penicillin, carbapenem, and cephalosporin, all these, it is absolutely useless, including your meropenem. It's absolutely useless to treat your MRSA. Okay, and the only one that can be used is ceftriaxone. Ceftriaxone I have not added in the spectrum. So ceftriaxone is a 5th generation cephalosporin, which can be used again MRSA. But all the other beta-lactams, once you have McA resistance, no use. So coming to now the glycopeptide, because usually whenever you have an MRSA infection, your drug of choice is vancomycin or your glycopeptides like teicoplanin or vancomycin. So what causes resistance to vancomycin? Now, for Staph aureus, vancomycin, if for an organism that is showing an MIC of less than or equal to 2 is considered to be susceptible, from 4 to 8 is considered to be intermediate, and from that is the vancomycin intermediate Staph aureus. And if it's more than 16, it is resistant, which is the vancomycin resistant Staph aureus. Now, this is something that this concept is something that you should be very clear. So there is VISA, there is VRSA. The mechanisms for VISA and VRSA are very different. VISA is usually because the organisms that expresses this kind of MICs, they have thicker cell wall, because your vancomycin, your teicoplanin, which are glycopeptides, they are cell wall inhibitors, right? Therefore, if the cell thickness is increased, it can cause kind of a resistance. But VRSA is because of VAN-A gene, VAN-A, like MEC-A, this is VAN-A, which is from the Enterococcus. They have received it from the Enterococcus species. And like I said, MEC-A, what happens? Lower affinity to beta-lactam. So VAN-K, it is nothing but lesser affinity to vancomycin, which causes VRSA. The rates are not so high in India, but this is a resistance mechanism that you need to know about when it comes to glycopeptides. Now let's come to one more case. A 60-year-old female presenting with chills and fever, hypertension. Cultures drawn, initially started on a meropenem, couple of days into her culture. It shows gram-positive cocaine culture clusters, Staphylococcus aureus, which is resistant to penicillin and sensitive to all other organisms. So how do you modify your treatment? So do you change, because you have started your patient on meropenem, do you want to change the patient to vancomycin as the MIC is quite low, less than 2 is good? Or you want to change to dicloxacillin, or do you want to change to cefazolin? Do you want to continue meropenem because it's sensitive? Or do you want to change to linezolid? Again, write down your answers so that you can compare later. All right. So because we are running short of time, I'll just proceed with the answer. It is C. You change to cefazolin. Now, I want to spend a couple of minutes on this question, because if you actually look at this question, you can either change to dicloxacillin, right? Because MSSA, the drug of choice usually is dicloxacillin, or your penicillin is resistant penicillins, but you have chosen a cephalosporin. Why? Because this patient has blood cultures. Oh, I'm sorry, I forgot to write that. It's a blood culture. A blood culture showing MRSA, or sorry, whatever, whether it is Staph, MR or MS, whether the blood culture is growing Staph aureus, you need to give IV. Now, dicloxacillin is not IV. Cloxacillin is. So if that was cloxacillin, B and C would have been okay. You could have given both. But cefazolin, because it is IV, you prefer that. That's the reason why the answer C is the most correct answer in this one. All right. So coming to the drug of choices for various infections for the pharmacotherapy of Staph aureus. For MSSA, always choose your penicillinase resistant penicillins and your cephalosporins. Vancomycin has been proven, showed by research, it is inferior to giving cefazolin. Okay, so MSSA, even if your patient is on meropenem, even if your patient is on teicoplanin, even if your patient is on vancomycin, bring it down to a lower generation cephalosporin. It works much better. For MRSA, the drug of choice is obviously vancomycin. But again, one major thing that I want to stress upon that everybody who's listening to me should take a note is something called the MIC creep. Over the years, there has been a shift in the MIC. That means more organisms are being more resistant. Okay. So, like I've told you in one of the previous slides, that MIC of less than 2 is supposed to be sensitive to vancomycin. But what people have noticed is that even with a sensitive MIC, that is, even if the previous case, I'll just show you this case. Even in this case, the MIC is less than 1. That means it's a good isolate. But if your patient is not responding after providing adequate therapy, if the clinical response that you're looking for is not being portrayed in a patient who is receiving vancomycin, this could be a reason. MIC creep could be a reason, and maybe think of an infection somewhere else, or is it because the vancomycin is not working well? Okay, so whenever you're treating an MRSA with vancomycin, even if your results are sensitive, if the patient is not responding well, always look back at your choice and see if anything better can be done. So some pearls that I want to provide you is that daptomycin is one of the best drugs you can give for Staph aureus, but you can never give it for pneumonia because the surfactant, the lung surfactant, can actually just wash it out. It can just degenerate the whole drug. TG-cycline is not good for bacteremia because TG-cycline does not stay much longer in the blood. And if you want to clear your blood from the infection, you need something much stronger that stays in your blood. And clindamycin, always when you see a Staph aureus, MRSA or MSSA, whatever you're looking at your culture, always look for erythromycin. Always look for erythromycin. If it is erythromycin resistant, you can't give clindamycin because different labs report things differently. Therefore, if it is erythromycin resistant, you can never give clindamycin, which is something called the D test. So the lower graph that you see here, this is erythromycin, this is clindamycin. Okay, so I'm sorry, please forgive me. This is a normal slide, normal Petri dish where, this is how usually when you put two discs together, one with no zone of inhibition, other with a full round. But when you have clindamycin and let's say you're putting clindamycin and you're putting your erythromycin here, instead of having a full circle, you get something like a D here. It's because the zone of inhibition of erythromycin is this much. It's a full circle. That means that it is inducible. Clindamycin resistance is inducible in that strain. Therefore, if your erythromycin is resistant, never give clindamycin. Now, when you have people who are coming with small, mild, skin infections, which are community acquired, if you think oral options like doxycycline, cotrimoxazole, and clindamycin are very good choices that you can give. Okay. Now, as a clinical pharmacist, I think this is one of the biggest thing. If anybody who's interested in an ID One easy thing that you can do in your hospitals is to look for staph bacteremia and treat them well. Okay. So what I started doing was that every day we used to go to the microbiology lab, take out all the culture positives, and this was one of our number one organisms. Any blood culture that is showing the staph aureus positive, we make sure that the patient is treated well. Because, like I said, because it's a very invasive bacteria, can cause multiple infections all around your body. Therefore, you have to treat it right from the beginning. Okay. Now, there are two ways of classifying, and IDSA have made it a point to classify the Staph aureus bacteremia into complicated versus uncomplicated. Okay. So, an uncomplicated bacteremia is defined when you have excluded endocarditis. That means the patient doesn't have, something on the valve or some vegetations on the valve causing an endocarditis. There are no prior processes for the patient. There are negative cultures within 2 days after the initial positive culture. That is your blood is getting cleared of bacteremia, and the fever and all the symptoms, the usual symptoms, usually defervescence within 3 days after starting therapy. And there are no evidence of a metastatic foci, multiple things in the spleen or in the liver or in your bone or in your vertebra. If none of these are there, it can be called as an uncomplicated bacteremia. The reason why you need to specify this, so these are things that you can make as your, what do I say, a protocol, whenever you see a Staph aureus bacteremia, classify into uncomplicated and complicated, because your duration depends on it. If it's an uncomplicated bacteremia, you give 14 days of therapy and that's it. You can sit peacefully knowing that the patient is going to do fine. But if it's a complicated bacteremia, then you have to give for 4 to 6 weeks or longer, depending on where the infection is. Now, we follow a bundle, and this is something that I've learned through practice. All ID physicians follow when they have a Staph aureus bacteremia. So how do you work up a Staph aureus bacteremia? You make sure each and everything of this is done. You always repeat your blood cultures. Day 1, it has shown positive. If possible, day 2, day 3, day 4, day 5, till you get a negative culture, or alternate days, you send the blood for culture to ensure that the bacteria is getting cleared. Okay, so you have to document clearance. If day 1, the patient is having bacteremia, day 3, the patient is having bacteremia, but day 5, it is showing no bacteria. So from day 5 onwards, you usually give for 14 days. That's how you treat an uncomplicated bacteremia. Okay, and remove all possible lines, all invasive lines that the patient is having, because that can go and be a foci there causing abscesses and things like that. Always pull out all the indwelling lines when you have it. Always rule out endocarditis. You can either do a transthoracic echocardiogram or a transesophageal echocardiogram, and wherever possible, get an ID consult, and if needed, an imaging to rule out other foci of infection is something that you can do. And when do you do a TE versus TTE? There are a lot of guidelines that you can follow up in the IDSA, or IDSA shows a good list of things where you need to prefer TEE over transthoracic echocardiogram. So I will not go into the details of it right now. Like I said before, if your blood is not, negative cultures are very important, because if your blood is not getting cleared of the bacteremia, there is something really wrong with that patient or the treatment, right? It can be either, like I said, if the patient is being treated by vancomycin, is it because of the MIC creep? Or is it because there are other foci or foci that you have not addressed? Some other abscesses, a prostatic abscess is there, or a liver abscess is there that is producing more organisms, and you're treating the bacteremia is not getting cleared, whether there's an infective endocarditis or the surgical debridement is not done properly. So always look for why is it there. And if it is the case and no foci or anything has been found, you can use a high dose daptomycin in combination with something like an aminoglycoside or rifampicin to treat this persistent bacteremia. So like I said, always remember, bacteria in blood, Staph aureus in blood, it can go everywhere and cause abscesses, and it can kill the patient. Now, the pearls that I want to leave to you is that bacteremia is usually because of a primary infection, which usually is a skin and soft tissue, or one of the lines that you've put in. So, and if a patient is coming to you, or a patient in your ward is complaining of development of back or joint pain, a few days history of acute onset of low back ache, joint pain, always a patient with bacteremia, always suspect vertebral osteomyelitis, and an imaging should be done, because this is called a hematogenous spread. From the blood, it is going and seeding some other areas. And vertebra is one of the most common area that you can get a Staph aureus infection. And the pulmonary infection, usually things that you have to look out for, and this is a board exam that you usually get. Following a viral pneumonia, if a patient is coming to you with consolidation, a necrotizing consolidation kind of thing, always think of staph. Staph can be one of the most, the worst culprit that can cause post-viral pneumonia. Okay, and if you have Staph aureus in your urine culture, it can either indicate, in the absence of a catheter, if the urine culture is yielding Staph aureus bacteria, it can be an indicator that there is bacteremia in your Staph aureus bacteremia. Therefore, take the blood samples also and culture to make sure bacteremia is there, or if it's there, treat it properly. So what is the role of combination therapy? Now, this is a very controversial topic, I would say. I want to just touch upon two major studies that has been done so far. That is the CAMERA study, CAMERA 1, which was done in 2016, and CAMERA 2, which was published in 2016, and CAMERA 2 in 2020. And then there is one landmark thing called the Staph study. So what they have done is that MRSA, like I told you, all beta-lactams are usually resistant, right? All beta-lactams are resistant. What they have tried to do is that even if it's resistant, when you're giving vancomycin, if you give a beta-lactam like a cefazolin kind of thing with the resistant cefazolin with vancomycin, will it cause a better outcome? Is what they have seen, what they have studied. And the initial CAMERA study was kind of promising, but the second one, they had to, because of high rates of ADR and electrolyte imbalance, they stopped the study. But what the Staph study was done in Detroit Medical Center, and I've been to DMC, and I've seen that they have a lot of Staph aureus bacteremia there. They have a wealth of Staph aureus data there, where I know that for a fact they follow this protocol, where if there is a Staph aureus bacteremia, they give cefazolin for the first 3 to 4 days, because in their experience, they say that it expels, or it clears the bacteremia rapidly than giving a single agent alone. So this is something that I've seen in practice, but not every hospital agrees to what they follow. But the Staph study also showed that this is something that can be done to clear out the bacteria, the Staph aureus bacteria at the earliest. Okay, so this slide I have taken from the SIDP and from this Rose et al., which shows that if a patient is coming with SIRS, sepsis, and if the patient is at high risk, maybe something combination therapy, something that you can give. And the combination therapies that they are talking about is daptomycin, ceftriaxone, or daptomycin plus an anti-staphylococcus beta-lactam, or a vancomycin plus a hydrophilic beta-lactam like a cefazolin kind of thing. Okay, so this is something that has still going on. And now coming to how do you prevent spread? So all of the following are, again, a question. All of the following are important infection control strategies in containing spread of MRSA in hospitals, except aggressive hand hygiene, routine nasal colonization, isolation of patients who are colonized, or routine antimicrobial prophylaxis for all patients hospitalized for more than 48 hours, aseptic management of skin lesions. Sorry. So in this one, you can see this is a very straightforward question. Just because you are getting admitted doesn't mean you have to give 48 hours of antimicrobial prophylaxis, to prevent MRSA. That's ridiculous. So the answer is D. You don't need to give antimicrobial prophylaxis. So something that has been done, the nasal PCR, because I told you a lot of people have colonization of the Staph aureus in the anterior nares. So you take a swab from your nostril and you do, whether it is for a patient who's coming sick, you do an MRSA screen and see if you are colonized. If it is colonized, do you need to give an antibiotic that covers MRSA is the question. So the good thing is that you don't say if you have it, treat it. But what they're saying is that if you're doing a swab culture and if you're not colonized, if you're having a pneumonia, okay, you're having a pneumonia, you're worried about MRSA. And if your MRSA rates are not so high, and if your anterior nasal PCR screen is coming as negative, it is of high negative predictive value. That means most likely 95 to 99% of the time, you will not have a Staph aureus pneumonia. The Staph aureus is not the one causing. So it's a negative predictive value. It's not saying if it is there, you treat. It's saying if it's negative, you can completely not give something. And one of the biggest studies that I could find was, the Veteran Affairs retro cohort studies, and you can see the negative predictive value. So if the anterior nares are 96.5%, so that means you don't have to cover that patient for an MRSA with an MRSA drug. Okay. Now the isolation practice is what you normally do. The contact practices, your hand hygiene, your gloves, things, your contacts, all these things are the routine practices that you help in preventing the spread of MRSA. And I want to leave you with the latest guidelines the UK has published recently, and it covers all these things. So the skin and soft tissue, urinary, bone and joint infection. This is MRSA, specifically for MRSA. So I would encourage you to go through this journal as well, so that you have a better idea of what is the current guidelines that is being followed. Now, towards the final slides, let's come to the next one. We have talked about Staph aureus so far. Now it's the Staph epidermidis. Okay, this is your cons, coagulase negative Staph aureus. Okay, cons. So 16-year-old bone marrow transplant patient with central venous line, 2 weeks, urinary catheter for 2 weeks, fever with WBC, which is very low, and the patient has not engrafted. 3 blood cultures are done, and all 3 grew Staph epidermidis. And which one is correct? Epidermidis organisms are likely to be sensitive to penicillin, likely to be from a surface of the urinary catheter, resistant to vancomycin, could be a contaminant, or epidermidis organisms are likely to be in a biofilm of the central venous catheter. Please write your answer. I'll give you 7 seconds because it's a large question. So you have 3 cultures growing Staph epidermidis. Now the correct answer is E, which is it is likely to form a biofilm in the central venous catheter. Okay. Now Staph epidermidis, like I told you, it is coagulase negative. So it's not so invasive, it's not so virulent, and they don't produce the exotoxins that I've told you about. And they are the part of the normal human flora on your skin, on your mucus, in your mucous membranes, and it's usually always hospital acquired. Problem with that, it's the potential of potency of the organism to produce biofilm, and usually they are considered contaminants when they grow in blood cultures. The one thing that I want to stress here is that if it's a patient who has underwent a recent surgery, or has a healthcare related procedure recently, and if more than one culture of that patient is showing cons, MR cons, it's always see if that could be the reason for the patient's presentation, if the patient is presenting with an infectious symptoms like fever and all that. Okay, so before discarding it as a contaminant, like every other day, just correlate with the clinical history of the patient as well. Now, these are the spectrum of things that it can cause, from catheter-associated bloodstream infection, which is a CLABSI, to prostatic valve endocarditis, peritoneal dialysis-related peritonitis, neonatal sepsis, shunt infection for CSF. And usually, these organisms are multi-drug resistant, and always the device or the line has to come out if it is infected. Vancomycin is the drug of choice. Maybe you can use, an aminoglycoside or a rifampicin, which is rifampicin is especially in the IDSA guidelines. They say that rifampicin can be used if it's a prosthetic joint infection. Something for synergy, you can add rifampicin. Okay, so this is regarding staph epidermidis. And regarding staph saprophyticus, just one sentence about saprophyticus is that it is one of the leading causes of urinary tract infection in sexually active females. Okay, so those who are newly married, when they come with a urinary tract infection, most of the times it's usually Staphylococcus saprophyticus causing the infection. So these are the major things that you need to know about Staphylococcus species. And the takeaways for you would be the Staph aureus infections are going to be, Staphylococcus infections are going to be on the rise, and the resistance is also growing. And it can range from a mild skin and soft tissue infection to a multi-organ dysfunction kind of thing. And the resistance, MRSA, it's MEK-A gene, and you have only limited options to treat the MRSA invasive infection. Vancomycin resistance is also on the rise. So whenever you are giving vancomycin, even if it is sensitive, if the patient is not responding well, always consider what could be the possible reason. Is it another foci, or is it your MIC creep? Do you need to change your drug? And for MSSA, for methicillin sensitive organism, your penicillin is susceptible penicillin, or the cephalosporins are something that you would choose over vancomycin. And for bacteremia, it is usually high mortality and high morbidity. Therefore, make sure you have a protocol that you follow for all the Staph aureus bacteremia in your hospital. And early combination therapy for Staph aureus bacteria is something that is being studied. And Staph epidermidis is usually, like I said, it's a healthcare associated infection. So any patient who had a recent surgery coming with Staph aureus epidermidis, before calling it a contaminant, always clinically correlate with the picture. So with that, I end my presentation. One other thing I wanted to tell all those who like to study clinical microbiology or ID, this first book that I've mentioned here, Mark Galvin for clinical microbiology, made ridiculously simple. It's actually ridiculously simple to read through this book. It's a very good book that I would urge all those who are interested in ID to build your basics in microbiology, because without microbiology, you can't advance in ID. All right. And so that's it. Thank you. If you have any questions, if there is time, I can take one or two questions. Over to you, Alia.
Thank you, ma'am. I think you covered as much as possible in this limited time. So before we go to the questions, I want to tell the participants that the feedback form will be made available in the comment box below the video thumbnail in the website. So your certificates will be given within 7 days after you complete the feedback form. So due to the time limit, we'll limit the question numbers, ma'am. First question is, how effective is lock therapy in case of Staphylococcus aureus? I'll repeat. How effective is
So
Staph aureus?
So for Staph aureus, the one thing is that if there is a line that can be taken out, always take it out. Don't go for lock therapy if that line can come out. But there are cases, like the pediatric PICC lines that, you've put, it's infected, and, you don't have a provision for another one because it's a baby. You don't want to puncture, the baby for a next line. In such cases, in this high concentration vancomycin may be used as a lock therapy. And the thing is, always classify your like I said, if it's a bag, because you're talking about a CLAPSI, right? Otherwise, you will not be asking me this question. Log therapy is for, a central line associated bloodstream infection. So if it's a CLAPSI, always think if it's a complicated or an uncomplicated, Staph aureus bacteremia. So, when your culture is coming, you think of your clinical picture. How harmful can that thing be? That bacteria be to that child or whoever you are treating, and if your risk versus benefit, if taking out the line will save the life of the patient, I would never ask you to risk keeping the line and do a log therapy. It's better the line come out, and only if it's unsalvageable line, maybe something that you can think of. But always on the other side, you have to make sure the bacteria and things like that is being cleared, and you don't have again things growing and patient developing fever every now and then. So in that case, yes, it can be given, but with caution.
Thank you, ma'am. Second question, what's the difference between visa and VRSA?
Which one? Visa and VRSA. Okay.
Yeah.
So visa, as I've told you, is the intermediate susceptibility. So it is the heterogeneous, there is a wild type. When you go through the microbiology books, the strains of organisms that you have the wild type, and you have the, wild type is something like, what do I say? Like when we were, the primitive humans, who are hunting and doing things like that. We are the first humans. Like that is a wild type. Okay, so that is the first, the actual strain, the original strain of the organism, and slowly things are evolving. Okay, so because it's a heterogeneous this evolution that results in this, a cell wall being more thickened. The like I told you, the peptidoglycan is in gram-positive is quite thick. So if it becomes more thick, for your vancomycin to go and act on your, D-alanine, that polymer, it is going to be difficult for it to just go and bind. So it can cause resistance, because it is difficult to create that pore in that peptidoglycan. So that is the reason for visa. And VRSA is something that you see. You've heard of VRE, the vancomycin resistant enterococci. Yeah, the vancomycin resistant enterococci, the Enterococcus specium that you have. So in those Enterococcus specium, there is something called a VAN-K gene, which is the reason why it is VRE. The VRE is because of this VAN-K gene, which has a lower affinity to this vancomycin. So the VRSA mechanism is because of that gene, but for visa, it's usually the evolution and this peptidoglycan being more thick is the reason for visa versus VRSA. So especially if you have something on the borderline MIC of 2 and like that, you don't have things to treat. That's when you are worried about visa. I think you are clear in your mind as to what I was trying to say. If you have any more questions, you can always put it, in the chat. I can always answer later. If it's not
Thank
clear.
you. Next question. How frequently blood cultures need to be repeated for staph bacteremia? And should we
Staph bacteremia, what they are saying is that, see, even what I say is staph bacteremia and fungal, the candida and candidemia, the fungal thing in blood. These are the two things that you take repeat cultures. Okay, so staph bacteremia and candidemia are always like going hand in hand, because the therapy, your rolling out your endocarditis, looking for ophthalmicin, looking for other foci, everything is similar. So ideally, the guidelines say daily. Daily, you have to take blood, draw blood, and see if it's growing. But it may not be practically possible. We do it every other day, day 1, day 3, day 5, and we see if it's getting cleared. If by day 5 it's not getting cleared, then we are getting worried. Are we missing something? Is there any other foci, anything yet need to be drained, or if the whatever debridement has been done, that can be done. So we follow every alternate day rather than daily. It
Ma'am,
can be
same question follow-up, and should we repeat even after it's negative once to confirm until we get two consecutive blood culture?
No, I didn't get you. Could you repeat that, Ali?
Same question, ma'am. The how frequently blood cultures need to be repeated. Second part of that question is, should we repeat it even after if it is negative once?
No, you don't need to. Once you have a negative culture, you don't have to repeat it. You will have to repeat it if it is, if the patient is not improving, if the patient is still having fevers, and your clinical response. When you give a drug, you expect a response. If that response is not there, maybe has something else grown, or is it coming back? That is something different. But if the patient is improving, you don't have to. If one negative culture is all you need, because from that day onwards you will start that as day 1, and then you'll give for 14 days of IV. So that's the reason why you need to document the clearance of bacteremia for staff.
Thank you. Next question. This is from chat box. There is a trend in surgery department at my hospital to treat MRSA, which is clindamycin resistant, with clindamycin and linezolid, or vancomycin for its antitoxin property. Is this justifiable?
It is very much justifiable in that way. See, surgeons usually tend to give clinda and linezolid even if it's resistant. So these are like, when you look at the, so let me just try and, so I hope you can see this picture. So if you look at all these drugs that you can give for MSSA, the lower ones are the ones that are used for, as protein synthesis inhibitors rather than, cell wall inhibitors. So when you inhibit protein synthesis, you inhibit the toxin production. So if you have an aggressive infection, like a cellulitis or like a necrotizing fasciitis, you must ideally, I would prefer to give clinda or linezolid for a patient. But if it is resistant, I would prefer the non-resistant one. But if both are resistant, then you have no other choice than to just give it because it will have some effect. See, the culture that you take is representative of a large number of colonies, right? It's just a representation of the large colonies. There will be a lot of other ones also that will be, intermediately susceptible to the drug that you're talking about. And clinda and linezolid should be for this, because of the toxin, it can be given. So these are the two drugs that you give, and it can be given if the patient, you are scared, patient is at high risk, if the patient is going into from a cellulitis to necrotizing fasciitis. Inhibiting the proteins, the toxins, is a brave move to do, or it's a very right thing to do.
Thank you, ma'am. Next question, it's also from chat box. It is in 2 parts. I'll say the first question to you. Is there any updates on triple therapy usage of MRSA bacteremia if repeated cultures are positive?
Triple therapy?
Yeah. Triple therapy usage for MRSA bacteria if cultures are positive.
I do not know what this triple therapy is about. Combination, what we have usually seen, like I've told you, is it's like an anti-Staphylococcus penicillin or a hydrophilic cephalosporin like cefazolin with an anti-MRSA agent is what I've seen. Or you have things like daptomycin plus aminoglycoside, thing like that. But I do not know what exactly this triple therapy that you're talking about. Is it addition of a protein inhibitor like clinda or linezolid? I did not get that question. I'm not used to the practice also.
Okay, ma'am. The second part of the question is some insights on use of levonorticloxacin.
I didn't get you.
Use of levonorticloxacin. Some insights.
See, it has not been marketed in India so far, and it is said to be one of a good fluoroquinolone agent with anti-MRSA effects, but till we have some clinical data or post-marketing surveillance data from the West, I don't think I'll be able to comment on that, because obviously without using it, even though how see like the one that you what is that thing? I forgot the other name. See, a drug can be very promising from the SAR mechanism and everything like that. But once you have the clinical data to correlate with it, I don't think because I have not used it in my practice. I have not seen anyone being using it here in India, so I might not be the right person to say anything regarding that. It is a promising drug, but we need to have clinical data.
Okay, thank you, ma'am. Participants, from tomorrow, all the basic modules will be made available in the website, HCPA official. And you can also have a download button below the thumbnails. So it will be easy for you to download it. And any sort of assistance or queries, please feel free to reach out at us at hcpaofficial@gmail.com. Thank you.